Welcome to the Four Eyes podcast, brought to you by YoungOD Connect. We give you a clear view into the young optometry world across Canada and the US, and we're your hosts, as always. I'm Dr. Amrit Bilkhu.
And I'm Dr. Deepan Kaur.
And we are kind of doing like a little spin-off, or I guess we could say like an update on one of our original episodes way back. Oh my goodness, like 4 years ago now. Holy moly.
Maybe even 5.
We started our podcast March 2020. So it's
March
almost
4th, 2020.
yeah, it's almost
Or that's when
been
we let out our first episode.
yeah, it's
Yeah.
almost been 5 whole years. Wow. So
Oh
I'm
my
still gonna say
God. Yeah, our
4 years.
anniversary's coming up.
Yeah, we should treat ourselves
Yeah.
by recording this late at night when I want to go to bed. No, but
Right.
we do it for the listeners. We do it for the listeners.
Yeah.
But for anyone who is not familiar with like our older episodes, way back when in our first year, we did an episode that's all about vision related headaches and how to identify when it's vision related versus non, and when is it urgent, all that kind of stuff. So we highly recommend you listen to that episode because it was way more professional than what we are
Yeah.
now. But it was very structured and organized, really good, like, quick tips on how to manage them. You know, 4 years later, Deepan and I, we've been in practice a lot and we've learned a lot of things along the way. And we said, why not refresh that episode with different things that we've learned, also including more tips on management of vision related headaches, because there's so many options out there. And then, yeah, we just want to talk about like what treatments we've used, what treatments are new and upcoming, and kind of go through like our own opinions on that. So yeah, I'm excited to reboot it.
Yes, me too.
For everyone listening, we want to go over understanding what different types of headaches actually are, just so that because there are tons of definitions to, define different types of headaches, and there are some certain characteristics that can make them all different.
I think the most common one, well, one that we're probably more interested in are the tension headaches because those are the ones that are more vision related.
Mhm.
So those are often caused by prolonged eye strain, like you're on a computer for a really long time, you're doing a lot of focused near work for a long time, and you're noticing that eye strain, whether you have the proper correction or not. Yeah, it could be due to poor posture, stress. You'll usually feel those headaches in the frontal area of your head or even on the side. You can
Mhm.
even feel some pressure behind your eyes. These usually occur more at the end of the day when you're doing all your computer or after you're doing all your computer work and your work. So these are people that work at a computer all day, work from home at a computer all day, students, because they
Yep.
are on a computer all day as well, or studying all day. Tension headaches is what I commonly will see at my clinic.
Yeah, definitely
Um,
me too. I'm
well,
not gonna
yeah.
lie, is everyone just not walking around with a tension headache now, like
Well, I
post
was gonna
COVID?
say,
Like
I know, and that's,
it's
this is the other
happening
thing too. When
everywhere.
you're in practice for a long time, the first thing you start thinking about is those tension headaches, and then you
Mhm.
start. The first question I'll ask is like, okay, how many hours are you on a computer or
Yeah.
your iPad or
And when does it
studying? Or
happen?
yeah, and when does it happen? So yeah, those are probably the most common ones you guys will see in clinic.
Mhm.
And then the lovely migraine headache.
Oh yeah.
So the headache is pretty severe. Like you feel it in a unilateral area of your head.
Mhm.
It kind of, you feel like this throbbing, pulsing feeling, and it's like moderate to severe pain intensity.
Mhm.
You also can most likely get nausea or vomiting with it and photophobia as well.
Yeah.
So these are like headaches where you are basically going into a dark room and avoiding all work together. And this can last for hours upon
Yeah.
hours. So it's not like something you can get through.
Yeah.
You have to stop all activity just to start feeling better. And you might have to take, like, sometimes Advil or Tylenol doesn't even help. Like, you
Yeah.
take
Yeah.
that, it doesn't work.
Totally.
So these are actual like migraines.
Yeah. I feel like
Um,
tension headaches are usually like that kind of dull throbbing ache. You can still kind of get through your day, right? People can kind of like walk around with a tension headache. They can still finish up
Yeah.
work, go
Like
home. But a
it's
migraine is
those
like,
moms that have like, you're like, do you have headaches? They're like, all the
all the time.
time. But they're still in, you're sitting in your chair. And you're like, okay,
Yeah, but a
but
migraine is more of like you really can't function. And
yeah.
then I find that a cluster headache is like worse than the migraine, right? It's cluster headache is like top of the line pain, the worst
Hmm.
you've ever felt. It's in
Hmm.
such a focal area, and I find that these ones are more like knife stabbing, right? Where you
Yes.
really feel like, okay, like something is wrong in my head.
Yes.
Almost like a drill is kind of like, working in there. I believe cluster headaches though happen for a shorter amount of time compared
Yes.
to migraines. Yeah.
And they usually happen to young males,
Oh, I
cluster
didn't know that.
headaches. Yeah, young males. So also with headaches, it's like it usually expands from the trigeminal nerve as well. So it can cause like meiosis, tearing, all this stuff too, just how it affects
Oh.
the neurons there. And it shouldn't be treated with Advil or Tylenol because there's a vasodilation effect, and those medications can make it worse.
Oh.
So usually people who have cluster headaches kind of already know that's what it is, and they'll just kind of probably use other kind of medications to help.
Hmm.
But
I'm not gonna
headaches.
lie. I think I'm very confident I have experienced a cluster headache once in my life. And that's so funny. It's like I remember the exact night. I remember exactly where I was.
Oh
I
gosh.
strongly believe that it was alcohol related
Oh,
because this was in,
yep.
right, like this was in university. It was a Christmas party that my roommates and I had. And, we drank a lot, a
Oh,
lot.
this was like back in
It's
undergrad
back
days.
in
I'm like, I
university
don't
days.
remember this in
No, no, no,
optometry
no.
school.
Back in
I
university
was, yeah.
days, we drank a lot. I remember waking up in the middle of the night. It's pitch black. I had a knife stabbing pain up in my parietal area, like on the left side of my
Gee.
head. I just sat up in bed. All of a sudden, cluster migraine. I felt like there was a knife going through my skull. And I panicked. I got so scared. I was tearing up. I was crying. Maybe my trigeminal nerve was involved. But I swear to you, I sat in bed in silence, just I couldn't function. And all of a sudden, after about a minute, it was completely gone. And I eventually went back to sleep. And I woke up that morning going, what happened to me last night? I thought I had an aneurysm. Like it was
Yeah.
so bad. So
But
yeah, I guess
it
it could
might,
have been alcohol triggered, right?
yeah. So
Yeah.
it can, yeah. I mean, I don't think cluster headaches are as common just because
Hmm.
off of, as long as I've been practicing, I really haven't seen many people
Yeah,
talk
I've
about
met like
cluster
one
headaches.
one or two patients talk about it.
Yeah. But I
Not
know
that
it's
many.
a brutal experience
Yeah.
to have. Oh, yes. And the other common one you'll see is definitely sinus headaches. This is usually,
Yes.
you can get pressure around the eyes, but it's usually related to sinus congestion. Rather than visual function. Some people who were just recently ill or sick will talk about having a headache because of that sinus congestion they're getting, or they have other sinus issues, and
Mhm.
they usually know, like, oh, my headache is from my sinus issues,
Do you know
etc.
what question I ask patients to see if it's a sinus versus a tension headache? Because those ones feel the same, right?
Yeah,
Especially with the orbital sinus cavities, they're always going to
yeah.
say the pain is still around the forehead. I always ask them if they can breathe through each nostril.
Oh,
Because
yes.
I get sinus headaches and it's always on the left side. And so my left nostril will not be as open or breathable as the other. And when I have those headaches, I know that it's more of a sinus related issue
Yes.
than just like from a BV issue, like from reading and all those things.
Exactly. Yeah. So
Yeah.
usually these won't happen after, prolonged near work or anything like
It
that.
can happen
Like
from lying down,
exactly.
right?
Yeah.
Yeah.
So
Bending over.
every time I get a cold, I'll get
Oh
sinus
yeah.
headaches because my nose is
100%.
stuffed up. I can't breathe through each nostril
Yeah,
very well.
exactly.
And then, yeah, I'll, these headaches can even come in the morning sometimes. Like I
Hmm.
think it could be
Totally.
sporadic, but yeah, that's a really good way to tell the
Hmm.
difference as well.
Cervicogenic headache. So basically, headaches that are related to neck posture and, shoulder tension, back tension. And I find that a lot more patients these days are complaining about headaches in the back of their skull, right? In the back of
Yes.
the head, top of the neck. And I find that when I did more research and when I talked to my own chiropractor about it, like the most common reason is the ergonomics and the posture of how you're sitting and looking down at your phones, slouching at a desk, especially with like work from home people. So those headaches you might notice more patients are complaining about them now, especially if they work
Hmm.
from home,
Yes.
or when kids are possibly the myopes, right? The kids that are myopic, leaning into the desk, looking really, really close at their paperwork, their shoulders are so tight. We all probably have some of that. And
Yeah.
so I wanted to add that because, yeah, I find that these days, I mean, posture is really causing huge issues with like headaches and just poor vision quality. So it's
Well,
really good to keep that in mind too.
it's interesting too in clinic. I'll get a lot of people when I ask about headaches, they'll be like, "Oh yeah, but it's not vision related. I get it because of my posture or neck, how I have my
Hmm.
neck positioned or and they're like, "Yeah, I don't know if that really affects my vision." And I'm like, "Actually, that can
Yeah, no,
completely
100%.
affect your vision." And they're like, "Oh." So I'm just like, "Yeah."
Posture related headaches, like those are things that even I pay attention to more now compared to
Mm,
4 years back. But I think what hasn't changed as much is the common visual conditions that cause those types of headaches, right?
yeah.
Especially the tension headaches. Like we said, the tension headaches are often the more vision related ones. Those headaches are around the forehead. They get worse throughout the day. And there's usually immediate relief when they take a nap or take a break from the eyes.
Yes.
And I mean, the most common causes that we all know that cause a vision related headache would be uncorrected refractive errors, right? That are
Hmm.
significantly causing blurry vision and then eventually squinting because it's
Yes.
always putting tension on the eyebrows. Accommodative issues, binocular vision issues, if they're getting some intermittent double vision, a decompensating
Oh yeah.
phoria, and then, of course, the photophobia, the light sensitivity. But
Mhm.
Deepon brought up another common cause of a vision related migraine off the podcast when we were kind of talking about this episode. She mentioned retinal migraines, and I want to learn more about
Yeah.
that because I don't know. I don't know what the difference of that is versus like a migraine with aura.
Yeah. So just stepping back a little bit. So when we were talking about migraine headaches, yes, you can get an aura with
Hmm.
your migraine. Usually auras are a binocular phenomenon. So people
Yeah.
will know scintillations, they'll notice like flashes of light, they'll get that kaleidoscope vision
Hmm.
in both eyes. It's not
Yeah.
just one eye. This is a little bit different than a actual like what is diagnosed as a retinal migraine. So the diagnosis of a retinal migraine is totally by exclusion. So you have to check everything else before even this patient is diagnosed with a retinal migraine.
Okay.
If this patient has been diagnosed before, they will tell you this in their history already, where they're like, oh, yeah, I get this retinal migraine. I did my whole workup with my
Mm-hmm.
family doctor and everything. I know what this is. If
Mm-hmm.
they never even heard of what a retinal migraine is, you got to send them out for
You have to
that
do
whole workup.
everything.
Yeah.
Okay.
So, again, the International Headache Society defines a retinal migraine as a fully reversible monocular visual disturbance that
Hmm.
is not attributed to another disorder or systemic issue or anything like that. And they define it as it's usually associated with a headache or migraine. But
Got
this
it.
definition is very limited because there's quite a few people who get these retinal migraines
Hmm.
and never experience a migraine or a
Just like a
headache.
migraine with aura, right? I mean, we usually
Yeah.
say like, yeah, you could totally have an aura. That's like a warning sign that a migraine will come. But
Yeah.
then some people just get the aura and then they don't get the migraine. Like they just don't
Exactly.
get the
Yeah.
migraine symptom.
Yeah.
So is it mainly because I would assume then with a retinal migraine, is it the same type of aura that they would notice binocularly? Like, do they get
So there that's
scintillations, kaleidoscope, or is it all random and different?
so retinal migraines are not really well understood.
Okay.
There is a variation of symptoms. You can get scintillations, you can get flashes of light, you can get scotomas, you can get
Yeah.
blackened vision. And I know that's, we're trying to figure out the difference between like, amaurosis fugax and all that
Yeah,
stuff,
because I'm
right?
like, is it a risk for stroke? Is it a retinal
Exactly.
detachment, or is it
But
a retinal
there,
migraine?
you can get symptoms from a retinal migraine where it can cause that reversible blacked out vision, but you don't have any issues with your
Okay.
systemic system or anything like that, right? So that's why they're a little bit more daunting and scary because imagine someone coming into your office and they're like,
Hmm.
"Oh, any changes to your vision?" And they're like, "Yeah, I get this like black gray patch on the left side of my eye. It like stays like
Comes
that for
and
20
goes.
minutes, but then it goes back to normal." And you're like, what? It's just like, what is happening
Actually,
here?
no, that's so interesting you say that now because I'm already thinking about two patients literally in the last like 6 months that have said that.
Yeah.
And they
Yeah.
have said, I have this thing where I get like flashes or I get this
Yeah.
blackout of my vision for 5 to 10 minutes and then it comes back and I've done a stroke workup. And because the minute
Yes.
they say it, I think, okay, we're gonna have to get a stroke workup done. And they'll
Yeah.
say, I already did it and everything was healthy.
Yeah.
But I didn't know about retinal migraine, so I educated them on, well, you know what? If you did the stroke workup like a year ago, well, something can change, do the stroke workup again. Like you just want
Yes.
to make sure you just keep doing it then, just to make
Yeah.
sure every year you rule it out. But I
Yes.
guess, yeah, that could have actually just been a retinal migraine if everything was healthy.
Yeah. Well,
Yeah.
I've had at least 6 patients like this in the last couple months, and I'm
Wow.
like, what is going on here? So
Yeah.
I had to look this up because I'm like, what is everyone just losing their vision right now? Like all these young people.
Losing their mind.
I know, but so these visual disturbances in a retinal migraine, they do last for about 5 to 20 minutes. It's not
Hmm.
maybe at most 60, but that's really pushing it.
Yeah.
And it can happen multiple times in a day.
Oh, wow.
But the triggers are similar to a trigger that you can get with a migraine. So,
Got it.
like stress or eating spicy foods or
Hmm.
being in a certain environment that triggers that. So,
Got it.
the retinal migraine usually occurs to patients that are under the age of 40 and
Mm.
usually will have a personal history or a family history of migraine.
Of
If they
migraines.
kind of tell you those aspects of their medical history, then you can kind of lean towards more of a possible retinal migraine. Again, like with the pathophysiology of a retinal migraine, no one really agrees to why it happens. It's
Yeah.
not similar to a aura that happens with a migraine. An aura is usually due to cortical spreading depression.
Hmm.
Basically, that means there's decreased levels of excitability in the cortex neurons of the brain, and that causes those auras binoculate. What they think is causing these retinal migraines is actually vasospasm. So, a
Yeah,
quick
makes sense.
constriction of your retinal vasculature. And I
That's what
believe
I
they
was
did a
thinking.
yeah, and I believe they did a study with fluorescein angiography on patients who were experiencing retinal migraines, and it showed that there was delayed filling of the central retinal artery and its branches,
Mm,
or there were patchy choroidal defects and
there you
capillary
go.
dropout. But this resolved once their episode was over, so it all filled
Hmm.
up again, and
Yeah,
they get their vision back. But
bounce right back.
it's a little bit nerve-wracking, right? Because if that vessel is like narrowing and
Well, that's
just
it. I'm still thinking like, okay, then that's still semi like a risk for stroke. So
yeah,
like
so like
it's
there's
still,
people with retinal
yeah.
who have had retinal migraines and had permanent vision loss, but they
Oh
all
my
their
gosh.
workups have been normal.
Have been
It's just
normal. Wow,
yeah,
that's actually really
it's
good to
like
know. Yeah, I didn't really know any detail about retinal migraine. So it's funny because now
mhm.
that I'm thinking, like, okay, anytime I hear patients talk
Yeah.
about this and I think about amaurosis fugax or whatever TIA, then I'm like, okay,
Yes.
we gotta check all of that. And then if you're normal, I still believe you. Like, you know what I
Yeah.
mean? Like, you're
I
not going
know. Yeah.
crazy.
I know. So this was the thing for me too, because when people would mention this and I'm like, did you go to your family doctor? Did you get all these checkups? Yeah, yeah, yeah.
Hmm.
Like everything is fine. And I'm like,
Hmm.
ugh, okay, how crazy is this person? And I'm like, okay, like any
I feel like
psychology,
every practice in like the staff room or something needs like a crazy meter. And then when like a patient comes in, you go to the back room and you just put it all the way up to red and be like, you know what?
yeah,
This patient made it to the meter
yeah,
today.
I know, but I mean,
Anytime
okay,
your
so
crazy meter reaches the top, then like the whole staff gets like
I
pizza,
know.
like a pizza party or something like we kind of teased into then just knowing in general and
Yes.
quickly updating you guys on when to make an urgent referral to neurology for certain types of headache symptoms. Of course, if a patient comes in and says, recently I've been experiencing an onset of a new headache, after you ask all those questions, if they grade the severity scale of this is the worst pain I've ever
Yeah.
experienced in my life, and it's in any part of the head or behind the eye, it could be things like, related to a stroke or subarachnoid hemorrhage. It could
Hmm.
be a tumor. It could even be an angle closure attack, right? So,
Yes.
you definitely want to make sure you refer, even if you see that everything looks healthy in the eyes. If that is the worst pain they've ever felt, it's always good to get it ruled out from neurology. Same with, of course, if they have any neurological symptoms along with the headache or around the same timeline when the headache symptoms developed. So the diplopia, the weakness, numbness, tingling in the limbs or the face, difficulty with speaking, a slurred speech, excessive fatigue that's just like not normal for these patients. You still want to send to neurology for any sort of a stroke or tumor. And then Deep One already mentioned when the optic nerve looks really funky, whether it's edematous, like with papilledema, or of course, if it looks pale, you still want to send to neurology and just make sure nothing's going on.
Yeah.
The papilledema can cause that raised intracranial pressure.
Yeah.
So we want to rule that stuff out. If they have that new onset headache in the temporal region for patients over 50, the biggest concern is giant cell arteritis. So, again, send them out for all of that cardiac workup and all that blood work. And if their headache, this one always makes me nervous as well. If their headache gets worse when changing positions, especially if their headache is worse when lying down, right? Sometimes
Hmm.
that could be sinus related, right? But
Hmm.
that's more, I find that that's more so if they feel the headache still in the frontal area of the head while they're lying down, then I feel
Yeah.
like that fluid from the sinus buildup can cause it. But if they have a generalized headache when they're lying down, or it gets significantly worse right when they sit up from lying down, like when they're getting out of bed, they could have pressure from a brain tumor or cerebral spinal fluid leakage.
Yes.
So, definitely send to neurology for those types of things just to rule out and make sure you covered your butt and make sure that your patient got everything thoroughly assessed just in case.
I feel like it's just like anyone who gets a headache, just do a workup on them to make sure they're
No, I mean,
like,
so this is what we really didn't go over in the previous episode we did related to headaches is talk about treatment options because like we said, the years have gone by. There's so many different treatment options out there for headaches. There's technology out there, there's tinted lenses, like there's specialty glasses, so many different things that we can talk about. And let's start with just how do we approach refractive errors to treat tension related headaches? I feel like I talk about how I deal with BV related headaches, right? With like glasses and refractive errors all the time on Instagram. So Deep One, why don't you start?
yeah, I mean, I'm coming from a more primary care point of view, but yeah, most of these patients will be presbyopic or have a latent hyperopic prescription or something like that. So you want to obviously prescribe them something for that near vision plus lenses like reading
Mhm.
glasses, computer glasses. Anti-fatigue lenses. Yes, I will do that for people who are even presbyopic. Like I'll put their
Yeah.
computer prescription on the top and then they're more
Their
that bit of a
reading
boost at
boost
the
like at the
bottom.
bottom.
Yes. So I'll do that. I don't necessarily do anti-fatigue lenses for students because I feel like they don't look through that part
Mm.
of the lens when they're reading because everyone has their laptop at eye level anyways.
Mm-hmm.
So sometimes I'll prescribe a separate pair of reading glasses for them.
Mm-hmm.
I don't know. I just feel like sometimes young people don't know how to use the lens and then it's not really helping them.
You know what? I'm gonna add to that. I don't know 100% if it's just they don't know how to use it. Large oversized glasses are a
Hmm.
huge thing right now. And
Yes.
and teenagers, oh my goodness, I think we already complained about this before in another episode. Teenagers are wearing oversized
Yes.
glasses, right? It's the librarian look that's really
Yeah.
in. So
Yeah.
yeah, they're not really getting the benefit out of the anti-fatigue. So it's kind of
Yes.
like pick or choose. If you want oversized, we're going to give you some single vision. If
Hmm.
you want the anti-fatigue for the benefit of just keeping them on while you're multitasking, you have to go for a shorter B length or B size on the
Yeah.
frame.
Prescribing reading glasses. Yeah, I don't do age related like reading glasses or whatever is
Yeah.
proper for their age. I do ask them where they hold their reading material and prescribe for that. I think
Yeah,
one
because
thing,
FYI, tension-related headaches will come from people prescribing an age-related ad that doesn't
yeah.
match their working distance.
And then yes, you do MEM
Yeah.
retinoscopy, which I don't do.
Yeah, I mean,
Maybe I should start, but what is
you know
this
what?
about?
That's my little secret. That's my little like
I know you talk about
superpowers, MEM.
I watched your Instagram videos this morning and I was like, I
MEM,
have to
MEM
dust off
retinoscopy.
my those little charts and start doing it because I'm like, oh
Yeah, if
my gosh,
anyone's
okay.
if anyone's interested learning more about MEM retinoscopy, I am sharing some patient cases on Instagram. I'm gonna make those cases highlights so that people can go back and review them anytime. But I do a lot of MEM retinoscopy. I don't think that everyone in primary care really has to do it, obviously, if you're not comfortable with it. But when you start to learn more about how the BV system works and where these headaches are coming from, when you do MEM retinoscopy, just as a reminder, that's you have the patient read something at Harman's distance with good lighting, and you quickly scope their ret reflexes while they're reading something. You quickly neutralize the reflex, but honestly, what you're looking for is you want the healthy MEM response to be they're a low plus zero point 0.5 reflex in both eyes. So if they're
Okay.
not and they're asymmetric, then you can always consider like just bumping up or bumping down the prescription in one eye that's asymmetric. So, for example, if there's a higher lag, a lot of width motion in one eye, that eye might benefit from a quarter more plus or zero point 0.5 more plus for near. That's like a little BV trick. If their MEM is asymmetric, I find that that's when those people get the tension headache over one side of their forehead. And then the minute you add a little bit of plus or whatever you do, they're immediately like, "Oh my God, I feel like both of my eyes are working together now."
Better. Okay.
So that's a little tip if you want to learn more. I'm always happy to share more on Instagram, so message me and we can always talk more. And then to transition into like BV related headaches, NeuroLens is something we wanted to bring up. And this is not a sponsored episode by NeuroLens. Both of us don't use NeuroLens, but I'm
Mhm.
familiar with it and I've learned about it. NeuroLens is a really cool specialty lens that can be used in a primary care setting. I personally think that it's a great add-on for a binocular vision clinic or like a vision therapy office. These are specialty lenses designed to relieve headaches, in addition to eye strain, discomfort, and some, diplopia caused by BVD. And it basically incorporates contoured prism. So the prism RX that it creates is customized and it's like a gradual increase or decrease in prism that varies at different areas of the lens. So it's basically like progressive prism, which is really cool. And the way that I don't know obviously all the technology behind it, but the way that they measure it is they have this device that the patient wears and they basically do a lot of eye tracking and phoria testing through that
Mhm.
machine at far and at near. So then it basically will blend all of that prism into the RX for far and near based on
Oh,
where the patient's looking. Yeah, the goal is to provide better alignment across different distances, right? Because our eyes are not working the same and not accommodating the same way for far versus near.
right.
So that's really cool. Like it's definitely a specialty lens. So the price is definitely different than a regular standard single vision prism lens. But they do also offer symptom surveys that you can like hand out to the patients so that you can screen who would really benefit from that lens if they scored significantly on that symptom survey. And so it's a more reliable way to let the patient know that they might want to invest in
Right.
a NeuroLens because it will significantly lower their symptoms. Yeah, I mean, there's been a lot of positive responses. I think it all depends because again, it's a specialty service. With any specialty service, I find that price is always something that
Hmm.
either patients are hesitant to pay for or ODs are hesitant to charge for, right? Because
Hmm.
ODs are too nice. And you're right, we're scared to talk about pricing with our patients and stuff like that.
I didn't know exactly how it worked.
Yeah.
But I know there's plenty of clinics that have the equipment for it for
Hmm.
NeuroLens, but I mean, again, when you prescribe prism and glasses, right? That's a fixed prism. It's not like that
Yeah.
progressive change. So that is actually interesting. And this can
Yeah.
definitely benefit a lot of people with binocular vision issues at the computer or, with their daily
Yeah.
life and everything like that.
But yeah, that's more so, specialty lenses in terms of like correcting refractive errors, correcting
Mm.
BV issues. And then everyone knows that tints are available for migraines, right? We know
Yes.
all about tinted lenses, but even then there's some new stuff on the market. Do you use any tinted lenses for migraine or headache patients ever? Or like
No.
even once in a while?
I think I tried the like the rose tinted
Oh, the
glasses or
FL-41s?
yes, yes, yeah.
Yeah,
Yes, the FL-41s. I've had really hit or miss situations with that.
me
So
too.
it's not really helping the actual problem, I feel like. So I'll have other discussions about migraines, about like what the trigger possibly is, or
Mhm.
their environment, their diet, all these kind of things, and are they working with their family doctor, who else is on their team for this. But no, I haven't really worked with tints for migraines or
Yeah,
headaches
I
really.
in the beginning as a new grad, I was definitely like all gung ho of like, okay, let's prescribe you an FL-41. The research
Well,
shows
those
it
were really
helps. And
popular
yeah, they were
back in
so
the day.
popular.
Yeah.
There were almost like blue light filters. Like blue light
Hmm.
filters just like kind of skyrocketed overnight in the market world. And
Yeah.
FL-41, it kind of happened like that too. One day we all
Yep.
woke up and were told FL-41 for your
Yeah.
migraines.
Yeah.
And no, I agree with you. I'm actually there with you. I feel like it was 50-50 in the beginning. And so that's why it didn't make sense to me. I was like, well, why? Like, why am I being told that it helps so many people? And then,
Yeah.
50% are basically like, meh, doesn't do
Yeah.
much. And it really is because tints can significantly reduce photophobia and,
Hmm.
migraines that are triggered by light sensitivity. But people have different visual systems, they have different hormonal triggers, and like they have a different autonomic nervous system than the person sitting next to them. And so everyone responds differently to every tint color. So I
Mm.
love to use tints, but I don't know, for me there isn't like a one go-to tint. I've had headache patients love the FL-41. They've loved a yellow. They've loved a brown. They've loved a blue. Like I haven't had anyone love a green, not yet, but like honestly, it really is just like it's up to the patient. You just have to have them walk around the optical with one tint on for a couple of minutes,
And
see
see
how
how
it
they
makes, and
feel.
you have to ask them like, how does this make you feel? And then they'll go like, I don't get it, like I can still see. And it's like, no, 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 no. You have to like get into your feelings and
Yeah.
like really just ask them, do your eyes feel calm? Do they feel
Yeah.
heavy? Do you feel tense right now? Do you feel angry? Like, yeah, you have to ask them what their emotions are. So I would highly recommend everyone not to just go to an FL-41, but just go to your tint options and
Hmm.
then show them kind of like every color or pick three, right? Pick three colors, have them look around. What I wanted to mention that I liked, again, I'm not getting paid to say this, but Hoya Lenses
Mm.
created this vision therapy tint book that I thought was really nice and really cool. The tint booklet was created with the suggestions from VT optometrists. So that
Mm.
is what I loved. And the book provides more customized tint options for like tons of different shades, and the tint percentage is much lower because I also find that you don't need more than 15%. You can actually even effectively do 3% of a tint and up to like 10 or 15. So it doesn't
Oh.
even, yeah, it doesn't need to be that big. And that's the thing, the patients might not feel it immediately, right? Like if you're going to
Hmm.
show them a 5% tint, they're going to be like, I don't see any difference.
Yeah.
Have to have them pause, take a look again, and ask them, no, 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 like not what do you see? How do you feel?
Feel. Yeah.
Then that light bulb will turn on. if you do have Hoya lenses in your practice, like I highly recommend reaching out to your rep and seeing if the tint book is something that you can get. And then you guys might have heard there's a new tinted migraine lens on the market, Avulux lenses. And I have Avulux lenses at my private practice. Deepon, you said that your practice brought it in, but then you left. So you haven't
Yes.
had like experience
Mm-mm.
with it yet.
No.
Did you try the demo at all?
No. So I like
Got
they
it.
brought it in. I was like, bye. I
Yeah.
like walked out. Like the Avalux reps walked in and it was like me walking out and I'm like,
No.
cool, Avalux. And I like just left.
Again, I'm not getting paid to say any of this. We brought it in because we thought it would be a really, really great option for migraine patients. I find that like the way that you can market it as an OD in your practice, it's similar to what I just said about NeuroLens. Avalux has like good marketing tools. They have like social media pictures and stuff that you can do and brochures, but they give you a symptom survey that you can
Mm,
then give to your patients because again, it is a specialty lens. It is pricey. But if the patient scores significantly high on that symptom survey, you're more confident that they are going to benefit from that lens. And it may not prevent the migraines from happening, but it can significantly reduce the intensity of that migraine so that at least they can function, right, while they're having a migraine. So, for anyone who
mm,
doesn't know what Avalux is, these are clinically tested migraine and light sensitivity management lenses that selectively filter specific wavelengths of light that have been linked to migraine triggers. So in their clinical trials, that's what they found. They found that migraines that are triggered by light sensitivity are often triggered by blue and amber wavelengths of light. And
mm.
interestingly enough, they found that green light can lower the intensity of the migraine. So the way that they created their tinted lens is to block out the blue and the amber, let in a bit more of the green.
Okay.
I basically have my vision therapist at one of my practices wearing them for me right now. She's my guinea pig. Yeah, because she gets monthly migraines related to
Oh,
her menstrual cycle. But she says that when the migraines are there, the light sensitivity is so intense. She's one of those in a dark room,
yeah.
vomiting, in bed, can't function.
But do
So
these have a tint as well? Like,
yes. So I've tried
oh,
them out just to see what the tint feels like. I honestly found like my vision was a lot clearer when I had them on, but it's very yellow. I just don't like yellow. Like again, I said everybody likes different colored tints, right? I'm not a yellow person. I love blue tints. Like for my
mm,
eyes, it's like, yeah, even FL-41, I don't like it. My
mm,
eyes are ugh, like so annoyed. The yellow was okay. It's not terrible, but it is pretty yellow. So they give you demo lenses so that people can try it in the office and just make sure
mhm.
like it's not too, uncomfortable for them. And so my therapist, she tried them out for a month now. And she said that when she had her migraine attack last month, she put them on and she said it was better. She's like, the migraine
Okay.
wasn't gone, but she said I could definitely function. Like I did not have to be in bed.
Oh,
So
okay.
that's a win for me. I'm like, great. Like I'm definitely gonna try to promote it more to my patients. Like I'm gonna try to,
Does she only
see
wear
who
it during her migraine attacks, or is
she
she trying
said
to
she
wear it
only
more?
put it on for the migraine. But yeah, if anyone's interested in Avalux lenses as well, like I highly recommend you look into it. See if that's something like again, another specialty lens option you want to add for tension headaches and migraine patients who are photophobic. Just play around with tints. Don't get stuck in a box thinking that it has to be one and nothing else. Just like
Yeah.
have fun with it and let them try like any color.
Isn't this kind of like syntonics
Yeah.
phototherapy?
Okay, that's funny. Yeah. Syntonics is
When you're
similar,
like
but just like
playing around.
different. Yeah, different but similar. Honestly, I'm still learning about Syntonics myself. I've
Mhm.
taken, I've watched a few online courses, I've read articles, I've read books on it. The purpose of Syntonics phototherapy is when we look through specific filtered lenses, whether it's light tints or very, very dark filtered lenses like the Syntonics goggles, wavelengths of light are absorbing through our blood vessels in the retina. The light is also then going to our hormone system, so our hypothalamus and our thalamus, pituitary gland, all those areas. And those areas are all responsible for hormone balancing, and our autonomic nervous system, right?
Hmm.
Sympathetic, parasympathetic, fight or flight, rest and digest. And so when patients have, autonomic dysfunction, when they have hormonal imbalances, if they have chronic illnesses like autoimmune conditions because of all those imbalances, or for head injury patients whose autonomic nervous
Okay.
system is now like out of whack, right? And
Yeah.
it's all dysfunctional. Syntonics can be a great option for those patients because depending on the wavelength of light or the filtered light that they respond best to,
Hmm.
when they wear those filters for a couple of minutes a day, it can help to rebalance their autonomic nervous system and
Hmm.
their hormones. This is a very similar concept to light therapy for jaundice
Hmm.
or light therapy for seasonal depressive disorder.
Yeah.
It's
Okay.
the same, it's the same thing, right? It's same concept, right? That when we shine light to an area where there are blood vessels, those blood vessels can absorb those wavelengths of light, spread to other parts of the body, our regulation systems, and then it can start to help regulate some of our functions. So just like light therapy starts regulating liver function, right? For jaundice. So it's funny to me that like we're so used to that knowledge, like of like light therapy helping other things. And then when we
Yeah.
say syntonics for eyes, people are like, which, like,
I know, like the
magic.
red light therapy and
Yeah, like
everything, the,
there you
blue
go.
light filters and all that
Red
stuff. Yeah.
light therapy is basically acting like a form of or a variation of syntonics phototherapy, right? And we're only okay with the red, but we're not okay with the upsilon and and like anything else. Like it's like, no,
Damn,
all black
Upsilon.
magic.
Which?
So again, like I think again, if you are interested in that stuff, you can always learn about it. There's the College of Syntonics of Optometry. You can learn about it there, the CSO. If you refer to BV docs, like you can always ask about syntonics and be like, oh, this patient has headaches, in addition to their BV issue. Like, would syntonics help? And your BV docs are going to be so happy that you asked. And then they're going to talk to you for 3 hours about it, be like, let me tell you about it.
How are these lenses different from like the Hoya tinted lenses that you're
I have to.
using?
The main difference from like a regular tinted lens and syntonics phototherapy is that syntonics filters are dark, like very, very dark. Like you can't
Oh,
even see things through it.
oh, so
So
you wouldn't wear
basically,
this
no, no,
day
no, no,
to
no. You
day.
would not. Syntonics is
Oh,
therapeutic. Like you wear them while you're sitting at
I see.
home, closing your
Not
eyes, or
full
just
time.
no, 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 no. You can't see any. It's like dark, like blacked
Okay.
out. You can hardly see because the purpose of them is not to help you see better and function. You're wearing them for a very short amount of time because I guess you could say it's a very heavy dose of that wavelength of light. You just want it to get
Oh,
absorbed, come in, do what it needs to do, and then you take it off after a few minutes.
I want to try this for my anxiety.
Oh,
It's the
that is
syntonics.
that is exactly what we use it for as well. Not just headaches.
I
Not
want
just
to try
headaches, but if
this for
anyone's ever
my
interested in learning more,
mental
you
health
can
issues.
learn more about it. Of course, Deepon already touched upon this. Maybe you can kind of go through this like who else can we co-manage with? Because again, when I
Oh
was
my
listening to our
God.
old episode, it's so different for me now versus back then.
Well,
Like,
I mean, you still can co-manage with all those same thousands of people that we said
yeah.
like 5 years ago. But I mean, yeah, like obviously, if you're going to be in a primary care setting, you got to talk to let the patient's family doctor know,
Hmm.
depending on how severe the headache is. And yeah, like what we talked about before, you might have to send them to the hospital right away if they're
Yeah.
showing other symptoms of like stroke, or GCA or all that stuff. But I think a big one for me that I've been doing is chiropractors and
Oh,
physio
yes.
for the neck, shoulders, the back,
Hmm.
kind of figuring out where that all stems from. But also, sometimes I will talk about to a naturopath doctor or
Yeah.
naturopathic doctor. I mean, I live in Alberta, so we're very like it's a very not as open-minded
Mm,
province when it
got
comes to
it.
these alternative sort of
Hmm.
therapies or medications. Not like saying anything bad about Alberta, but I'm just saying like there's a different mindset here when it comes to that.
Yeah.
So I'll bring it up, or I'll be like maybe talk to a dietitian or a nutritionist about what could be causing these, like trying to
Hmm.
take a more holistic point of view.
Yeah.
But again, I feel like that hasn't always worked for me, but when I talk about chiropractors and physio, I'll definitely bring that into the conversation.
Hmm. It's
So,
funny you mentioned like the mindset of Albertans. And yeah, like obviously you're just generalizing. That might not be true, but obviously you deal with that patient population all the time. So if that's
mhm,
the reaction you're getting, then obviously there's some pattern there.
mhm.
Because that's so funny. In Ontario, I get the exact opposite reaction. Like 90% of the time. I find that in Ontario, again, I think in Canada, our universal healthcare system has pros and cons.
Mhm.
And one con is definitely just our healthcare
Yes.
system. We do not have enough family doctors available for the population that's significantly growing. And the wait times to even see family doctors and family medicine is like months to
Yeah.
years, right?
Yeah.
My patients are very open to seeing somebody else and willing
Mm.
to pay out of pocket or use private insurance plans because they know that they can then see somebody
Yeah.
earlier, and try something else while they're waiting for their family doctor's appointment or to be registered to a family
Yeah.
doctor because a lot of people
Right.
still aren't, which is
Right.
really sad. And I'm not going to lie, I usually tell patients like I am more of a functional medicine mindset now, anyways, compared to 4 or 5 years ago when we recorded the first episode.
Hmm.
My chronic headaches and pains and back pains and my hormonal imbalances, my thyroid dysfunction, my MS like symptoms in my hand that I've been dealing with for like almost 2 years now, all of those things significantly reduced and almost fully resolved after I worked with a naturopath and a holistic chiropractor who
Mm.
deals with spinal misalignments rather than pain management. And even with the naturopath, like then from that naturopath, I learned about, lymphatic drainage massages
Yeah.
rather than pain massages. Learning how to do more stretching, journaling, like all these other things, and changing diet. I've gone caffeine free, gluten free. I'm lactose free now. Like, obviously, this was not all overnight. This was a
Mm-hmm.
2 year journey.
Hmm.
And now I'm at a place where I'm so much better than 2 years ago.
Hmm.
But I think that alternative medicine is for patients who I think are more motivated for long-term resolution and management
Yes.
rather
I think,
than short-term resolution.
yeah, I think that's the key word, the motivation part you're
It's
talking about.
motivation. It has to be.
Um, yeah, obviously we're still in a society where it's like more of
Hmm.
a quick fix situation. I
Yes.
still get patients with their kids coming in, where they go to a family doctor because of an eye infection and they're just handed an eye
Yeah.
infection, quote unquote, which is not a real
Yeah.
eye infection, and they
Hmm.
just are given antibiotic eye drops. And the
Yep.
parents will come in and be like, "Can you just prescribe me more of those drops?" And I'm like,
Like, how do you
let's
just
just have a
want that?
conversation right now. We're gonna sit
Yeah.
down and talk about some stuff,
Yeah.
and then it's just I like to be from more of a holistic approach as well, but it's just I think yeah, on the western side of Canada a little bit, it's more prescribe me something, just
Yes.
prescribe me something because I don't
Yep.
want to pay for this, and I don't have time to do
And I
that,
don't want to wait.
that.
I don't have time. Yeah.
Yeah.
Yeah. Don't want to wait.
So, and most of these people do have family doctors and things like that, but I don't really notice a lot of, like there's a kind of population here that has that holistic
Hmm.
approach that is not as popular here, I would say, as it probably is in, Vancouver,
Yeah.
BC and Ontario.
Just say
Yeah.
it, deep on. You live in cowboy country.
Yep. Yep.
If
So
anyone who's not
this is,
familiar with Alberta, that is basically the wild, wild west of
yeah,
Canada. So
yeah.
I loved this comprehensive like summary of types of headaches, how to
Hmm.
manage them, how to co-manage with them. Because yeah, it's really interesting even to see us as how we handled and thought about headaches as new grads And now
Yes.
just as young ODs, like practicing 5 years out or whatever, like this, I like to see the growth, the transition. But yeah, it's good to like go over it. So I hope that this helped everyone that listened and gave you guys like a good summary of vision related headaches. If there's any information that you wanted to add, any other tips, again, Deepon and I love learning from anyone who listens and shares their opinions with us. So DM us and give us a message and let us know if you thought anything was interesting or if you have your own tips on how to manage certain types of headaches that you've had in your chair.
Thanks for listening to Four Eyes, the podcast series brought to you by YoungOD Connect. Be sure to subscribe and follow us on Instagram or YouTube at Four Eyes Optom for more content. We'll see you guys next time. Bye.
Bye.